복싱 로고랑 인대계 소량 중션이 좀 다시 뚝 떠버려 많이 쓰게 됐거든요. 제가 이런
EGM 컨퍼런스 시작하겠습니다. 현재는 76세 여환이고 증상이 없는 에이트리얼 플러터로 시술을 위해서 했었고 과거력으로는 AVRT를 1991년도 1996년도에 이제 레프트 라테랄 액세스 패스웨이에 대해서 오블레이션을 하셨던 분입니다. 프락시즘의 AP의 타키카디아, 브라디카디아 신드롬이 있어서 DDR 페이스메이커를 2019년도에 삽입을 했었던 과거력이 있습니다. 그래서 디바이스 팔로우업을 하던 중에는 계속 AP만 확인됐었는데 디바이스에서도 이제 플러터로 생각되는 리듬이 관찰됐었고 11리드 ECG에서도 플러터 리듬이 관찰됐습니다. 수제 AVP에서 네거티브로 생각돼서 티피컬 플러터로 생각이 되었던 환자였고 그래서 시술을 계획해서 PVI와 CTI 블록을 진행했었습니다. 시술 중에는 사이너스 리듬이 계속 유지되고 있었고 최대 인덕션을 따로 하지는 않았었습니다. 그 이후에 그 이후에 11리드 ECG
그래가지고
이후에 11리드 ECG 외래에서 팔로우업을 했을 때 환자는 증상이 없는 상태였지만 이전 ECG와 비교했을 때 V1에서 QRS가 통통해져 있는 것처럼 보이는 부분이 있었고 P웨이브가 같이 섞여 있는 것으로 생각이 됐습니다. ATP칼 플러터가 같이 동반되어 있는 심정도로 판단이 돼서 다시 재시술을 계획을 했습니다. 체스트 엑스레이
Hang on a second. Is this ECG that you shown? What kind of flutter is this? This is a right atrial flutter, you think? What's a flutter wave looks like? In that the lead 2 is a positive? Not a positive? Lead 2. The bottom tracing. Yeah, there. Especially when you're pacing. I assume that's a pacemaker activity going on. But when you pace, there's no QRS complex overlap. No. Go to lead 2, bottom street. Yeah, during the pacing. And that's a flutter ongoing. The lead is a positive flutter wave, right? Is it positive? So what kind of flutter is this? You're assuming this is not a right atrial flutter. Is it?
네, 맞습니다.
So when you look at the ECG, especially patient underwent complex procedures, we need to try to gather as much as information as possible from clinically as well as the ECG was. So is this vector of a flutter wave is not a consistent of the right atrial flutter. Especially if you look at the lead 1 is a flat, maybe AVR looks like a negative almost. Can you see it? AVL? Go look at the AVL, same. Yeah, is it not negative? Negative looks to me. So then it's coming to the left to the right. And then I cannot tell in the V1 whether it's a positive or negative, but then anyhow, EKG morphology of patterns is not a classical ECM dependent flutter, right? That much you can read in your ECG, and then you can start thinking about your procedure, right? Also, looks like lateral leads B4, B5, B6 is a positive as well. You see it? B4, B5, yeah. Second bit, go to second bit. Next one. End of the T wave, yeah. And then subsequent, you even see a better. Next bit, you can see even better flutter wave. Yeah, there we go. So even your first ECG that you show, even patient is a presentation, and then I know you guys did the flutter or CTI there, but the EKG doesn't look like a classical flutter wave. So anyhow, okay. So what's the differential diagnosis? Somebody had a PVI. Somebody had a PVI. You have a relatively regular tachycardia, correct? It's pretty fast, about 300 beat per 280 beat per minute, consists of the flutter. What other scenario you can think about it? Post atrial fibrillation ablation. What happens if you do pulmonary vein isolation and then is incomplete? Sometimes patients come with a post-ablation atrial tachycardia, very fast tachycardia, because the PV inside is probably re-entrant atrial flutter tachycardia going on. But you have an exit site is limited to the previous ablation, then you behave like a focal atrial tachycardia. But the mechanism of those tachycardia are still pulmonary vein macro re-entry, right? And that kind of modeling of arrhythmia is one of the reasons why your concealed entrainment does not work, does not confirm diagnosis. Remember last ERC, Kim Jun presented a case of ischemic VT, pretty extensive scar. And then William Han and raised the question whether that entrainment was right or wrong. It is one of such example. Could be. So you need to start thinking those things. Okay? All right, let's go.
엑스레이에서는 카디오메갈리 소견이 나타나고 있고, 혈관 컨제스션 소견이 나오고 있고, 디바이스가 들어가 있는 소견이 확인되었습니다. 그래서 EP 스터디와 오블레이션을 계획을 했고, 카테터 포지션을 일단 처음에 데카나브 카테터를 CS로 넣고, 디오데카폴라 카테터를 CS 프로ximal과 RA에 위치를 시켜서 이제 라이트 사이드와 레프트 사이드를 구분하고자 했습니다. 그래서 이니셜 리듬은 근데 이게 진입이 잘 많이 안 돼서 정확한 상태에서 이제 이니셜 리듬을 확인했었고, 월리스트 A가 그 데카나브 카테터에서 가장 빠르게 것을 확인할 수가 있었어요. 타키카디아 사이클링스는 340 밀리세컨드 정도로 확인됐었어요. 그래서 세탈 펑처를 이제 하던 중에 이제 좀 더 깊이 데카나브 카테터를 위치시키는 데 성공을 했었고, 옥타레이 카테터를 이용해서 매핑을 같이 진행을 했습니다. 각 PV 매핑을 이제 확인을 했는데, LI PV에서는 아이솔레이션이 확인됐던 게 확인됐고, LS PV에서는 아이솔레이션 되지 않는 것이 확인됐고, RS PV와 RI PV 모두 아이솔레이션이 확인이 됐었습니다.
So did you able to case from this left superior pulmonary vein? Did you guys try to entrain this from the left pulmonary vein? See what happened? Or no?
지금부터는 하진 않았습니다.
And so next time you do it, because it's going to be important for you to do. If you look at the tracing, go back there. You got PV tachycardia going on. It's one-to-one relationship. And it looks like in my eye, if you draw the line, in pulmonary vein, it looks like earlier than anything else. Because your atrial is a bystander, okay? I think the CS activation distal has a far field, and then you get almost all potential there. Look at the CS1-2. Yeah, there's a before that. Just, no, you're going too fast. That's a local potential. Go forward, a little bit, no, 앞으로. 거기 말고, no, 빨라. Come back. Right there, you just passed. No, CS1-2, 1-2. 조금 더 왼쪽 와봐. 조금만 더. Right there. You have a consistent every signal. Do you agree with me? Do you see that signal every bit, right? Okay. Next bit. Another one in the front. So if you look at that, if that's a double potential, right? You have to think that either that is very early or very late, because that is almost standing by itself, middle of nowhere. So that far field signal, probably I would try to map it. But before you do that, since the pulmonary vein potential is earlier than your CS distal, you could entrain from there to figure out what happened with that far field potential. That will give you a clue what to do with it. Okay? 대답이 없어. 그러니까 next time when you see this typical regular tachycardia, it's more reason for you to start understanding about this tachycardia. Okay.
네,
영어를 본다고
알겠습니다.
해서 그런 거냐?
Okay, let's go. All right. Yeah, that signal is still there. Okay. So you didn't check that. Okay, good.
ECG 매핑에서도 LSPB 클리니아 근처에서 아이솔레이션 안 된 듯한 소견이 관찰되고 있었어요. 나머지 PV에서는 다 아이솔레이션이 확인되고 있었고, 그래서 울트라이 카테터로 매핑을 하던 중에 LA 사이드에서 포스테로 라테랄 월에서 더블 포텐셜이 확인이 됐었습니다.
Mhm.
그래서 해당 부위 근처로 해서 LA 매핑을 다 진행해서 프로파게이션 맵을 확인했었고, 프로파게이션 맵에서 포스테로 라테랄 월의 솔로 컨덕션 존과 함께 리엔트리로 생각되는 마크로 리엔트리로 생각되는 리듬이 확인됐었고, 사이클 랭스를 모두 커버하는 것을 확인할
So
수가 있습니다.
this tachycardia was a PV around the PV os coronary oriented tachycardia.
그래서 코헤런트 몇 가지 확인을 해서 PV도 돌고 페리마이탈도 같이 도는 듯한.
And what's the story? Where's the focus? How do you explain this? So you're trying to say to me this is a figure eight reentry, right? Because you said the PV reentry as well as the perimitral, right? So can you go back to the your mapping tracing there? There was an interesting EGM there that you did not point out. Yeah. Yeah, that one. So where you think that this is early, mid, late going to be? Can you tell me? You pointed out where? Or octave 3, 4, mid, that's early? That's a meaningful signal? I want to know that question. Anybody answer this question for me? What do you think about this potential he keeps pointing out? Is that a meaningful signal? Yes or no? Would it be a candidate for the ablation?
그 시그널 말씀하신 거야?
So he pointing, I think it has a big A, a small fragment potential. Yes. Am I right? That's why you're calling double potential?
그 위치가 어디예요? OA가?
방금 보여줬던 LA 포스테로 라테랄 월 여기서 이제
Lateral.
이게 포스가 나타나는.
So you know, actually, if I may I ask you, that potential actually start from OH12, not OA12. H. There we go. H. That's it. You got small potential. Right after that, local A, focal A. Do you see it? That activity is much earlier than what you're pointing OA 3, 4 or 1, 2, whichever you're pointing out earlier. Now, what is more important there? Is that signal? If you look carefully, right after that high frequency spike, there's another noisy signal, very slow level noisy. Take a look. Come back slowly. No, come back slowly. Right there. No, you just passed that guy. No, you just passed right there. Stop. Yes. That both signal polarity is what? If you get imagination is a positive. Your A initial is a negative. Okay? You see it? You agree with me? Your local A, broad wide signal, is a negative. And then the sharp potential is positive. Now, here you got a local A and the fragment signal right next to each other, following A. Therefore, this is what? Yeah, you see that's a late. That signal is later than what you're pointing. OH12 is the probably the target of your ablation. If you look at the signal again. So if you go back there, you're tracing, gain up that signal, take a look. I bet you that both signals are positive. The fragment signal too. So right, next guy. Yeah, that's that positive initial and then the second positive. So that probably is the channel that this thing coming up. So yeah, when you guys look at the high resolution mapping signals, their level of recording can be low as 0.1 millivolt or sometimes 0.05 Orion case. So you really have to pay attention what you're doing. Otherwise, you misunderstand the diagnosis. So you go back to your map now. So you're showing the propagation rotating, looks like a counterclockwise along the pulmonary vein. Okay. What other possibilities exist here? What do you think that to imagine? What other possibilities you can think?
포텐셜 가능성은 없나요, 선생님?
Pardon me? 뭐라 그랬어?
마샬 베인 포텐셜 가능성은 없나요?
Yes,
왜냐하면
it is. That's exactly what I'm trying to point out.
예,
So,
크라임 쪽으로 해가지고
right, this is actually epicardial fiber breaking through. That looks like that way. That's what I'm trying to point to you. That far field signal that I'm pointing, very low level, low frequency signal. That is typically what you see in epicardial potential from endocardium. So this is epicardial breakthrough of ligand Marshall involving tachycardia. So I bet you, because we did not complete the tachycardia circuit, since we did not do epicardial mapping on this patient, probably patient focus only involve left anterior carina and the ligand Marshall reach. I think that's only involved. So that's why it's so important you try to entrain from the macroentry mitral valve annulus as well as the posterior to see which response you get. That's why before you burn it, instead of Caro guys or Navics guys tell you where things are, this is just cartoon. You have to validate your idea. So you would entrain from there to make sure that which one entrain perfect. Then you want to ablate that area. You don't want to be ablating different places. Okay?
근데 위도 들어가 보면은 저런 케이스를 종종 보는데요. 특히 랩사이드 펄머니 베인 쪽에서는 그 위엔트랑 타키카드는 저 시그널을 종종 보는데 마샬 베인 포텐셜이라면 에피카디알 스트럭처인데도 불구하고 캐라이나 쪽에서 어블레이션 하고 나면은 하면서 터미네이션 되거나 아예 인덕션 안 되는 경우들이 많거든요. 근데 그렇게 엔도카디알 어블레이션 한 걸로 충분하다고 봐도 되나요?
Yes, we did early days all epicardial mapping, like a Marshall case. And we stopped doing that. The reason is because with the irrigation ablation that we use currently, if you do 35 watts for, good 60 seconds to 90 seconds, you can get rid of it. We have a data. We are recording simultaneous epicardial Marshall bone potential. You ablate from endocardium and then get rid of all that. That's why we stopped doing epicardial mapping in venous Marshall cases. Okay.
타겟 포인트는 어떻게 잡으세요, 선생님?
That's the reason that when we do PV isolation to avoid just later complication, this kind of such recurrence, we ablate the carina pretty widely, including ridge, right? So that's why you mostly get rid of altogether. So we ablate the carina first, always, and left anterior carina widely first, half of the superior pulmonary vein, half of the inferior vein, and then triangle shape, and then we ablate all that area. So that get rid of three things. One, you will get rid of the carina fiber, which cross over between the right and left, left superior inferior pulmonary vein on the left side, and then ligand Marshall and epicardial, subtopondal coming down as well, and then GP, sympathetic innervation. You get rid of all that. So you can demonstrate that doing epicardial mapping as well, but you don't have to do that anymore. When we used to not have irrigation catheter, we had a problem with that, but not anymore. We haven't seen much, okay? The most case that I see when I visit our fellows in Korea, some other area, and they do multiple PVI, and then they continue to have a tachycardia, usually go in, typically this is the area because they did not ablate the carina wide enough. So, because of recurrence of PV reconnection most common in carina anyway, both either right or left pulmonary veins, it's important to ablate a little more generously in anterior carotid of left right suprapulmonary vein, inferior pulmonary vein together. Okay, you don't have any complication of ablating extensively this area. First of all, there's no nerve. Second, there is no stenosis. Third, there's no vital structure that you're going to damage. There's no esophagus. There's a pharynx nerve. There's nothing. So there's no really reason to really worry about that. Now, when you do alcohol injection, okay, you often miss this area because alcohol injection only selectively eliminate the endomyocardium, does not get rid of the epicardial fiber connection because Beta Marshall does not supply those areas. So we see that time to time also. Post-alcohol ablation, patient come with the atrial flutter, and then they usually have a two gap. One is the mitral valve isthmus annular area, and second most common would be that Beta Marshall connection. Okay. According to Miguel, he's thinking get rid of it, but you don't. We studied that before. I have a few patients from him as well. So.
그럼 여기 질문 하나 좀 더 드리겠습니다.
Yes.
특히 아이솔레이션이나 포스트 메이즈 리컨 타키카디아 때
Yes.
레프트 사이드에서 보는 경우에 그런 에피카디아 컨덕션이 문제가 되는 경우가 제일 많은 것 같은데요. 엔도카디움에서는 아무런 시그널도 없는데 이
Right.
수술 잘 된 환자들 보면은 그럼에도 불구하고 에피카디움을 도는 저 마이크로벤티가 계속 남아있는 경우가 있는데 그런 경우에는 매핑을 어떻게 하십니까?
Usually, trouble is that you can look at the two way. One, when you not during the tachycardia, okay, during the sinus rhythm or during the CS pacing, we like to do CS pacing rhythm baseline mapping. If a patient does not have a clinical tachycardia inducible, or patient has a clinical tachycardia inducible, suggestible, let's say that the Bachman bundle roof dependent tachycardia gap or something like that. Then what we do pace, and then we do bipolar, unipolar voltage map for endocardium. But look at the discrepancy between the unipolar bipolar threshold and the voltage map change gradient we're talking. That gives you some idea that the deeper tissue viability is present there. Now, atrial flutter of a surgical maze cases, typically gap that you see is they are not only strict to the epicardium only, they're transmittal. Unless you're doing a cryoablation and things like that, which is tend to give a more heterogeneous scar, then you can be more problem. But if you do surgical coxswain maze, not really much that kind of problem. So depend on what energy source they use a surgeon. So a surgeon uses a cryo, then you're gonna have some epi-angle discrepancy, okay? But then some patients do bipolar Medtronic, for example, ablation. They do fairly well, except that you're going to have some gap in the tentative edge area, which is going to be left lateral ridge high or coronary sinus area. And typically that's what we see. Now, coxswain maze, in our experience, the most common epicardial focus is actually when the surgeon do cryoablation between the mitral annulus and the coronary sinus because he worried about the circumflex artery. So they don't cut that area, they just cryo button. And those are typically more reconnection. Those you need to ablate from the coronary sinus inside, not the outside. And we have not had to go epicardially with the surgical, help to get the epicardial ablation. We usually tended to map and then high voltage area if there is, and then we do endocardial ablation. It works okay, pretty good. We haven't had much problem. Maybe when you have a case, maybe you can show me what you're doing, and then maybe we can figure out what's going on. Okay. So you're happy with your map? If you look at your mapping here, take a look carefully. Hold there, just watch it. What happened? How come inferior pulmonary vein activated earlier than posterior? Go back, left inferior pulmonary vein, anterior pulmonary vein. Go back pulmonary vein, yeah, let's take a look at this map. When you guys create a beautiful map, you want to appreciate that for a while. What happened here? You see, the wavefront coming up from mitral valve posterior. You said there's a posterior reentry. But take a look. The very beginning, and the impulse comes up. Don't rotate it. Just leave the way it is. And then what happening is that that impulse comes up posteriorly, and then they're hugging posterior the inferior pulmonary vein. But at the same time, very small potentials moving anteriorly toward the carina. Take a look. Like that. But yeah, you said the PVI was a complete, except the left pulmonary vein. So typically in this kind of patient, what you end up seeing, because of appendage tended to fit lower than usual, okay? Am I right? This patient has appendage in the front, right? Rotate the map a little bit. Let's see. Okay. So you got basically that black picture is what? That's the virtual CT image, the overlay. That's what you're doing. So your appendage far field the signal are probably contaminating your left inferior pulmonary vein potential. Looks like. So those one, you need to make sure that the mapper knows that. Make sure you teach the guy so he doesn't make the same mistake again. Take a look. I mean, this is a contamination. So your map should be cleaned up before you look at it. I'm not sure your map is accurate because for me, when you tell me either re-entry pulmonary vein, no, it's not a re-entry pulmonary, it's colliding right at the posterior carina, this thing. Right there. You see that? So you need to figure out where that impulse is coming from. If that was a true map, then is more reason to suggest that this is epicardial breakthrough between anterior carina and ligament marshal lower insertion. So if you entrained it, they could tell you that far field signal that I point out to you. So you need to familiarize your eyes to the low level potentials now, especially if you're looking at the high resolution mapping, okay? It's not like SVT or anything like that. Tools are getting better. Signal, quality recording is going to be all low amplitude, a lot more than usual typically. And so it is important that you keep looking at the map and the EGM as well as a fellows trained from now. Is important. It's not just a Pruka EGM. All right, guys. So patient successfully terminated. What happened? Okay.
아, 잘
Okay.
이제 들립니다.
Okay. I think you just need to correct a little bit of your map. That'd be perfect. Okay.
설명하신 거 하나도 못 들었어요. 지금 오디오가 문제가 있어서. 또안 되나?
아니요, 지금 말씀 안 하시고 있습니다.
아니 지금 보면은 그 타키카리아가 I think it looks like a more sort of a epicardial breakthrough. Okay, that's what I think it's looking at it. That's why your EKG looks like, and then breakthrough is the same. Okay. So don't trust too much in 3D. Okay.
교수님 아까 코멘트가 오디오가 나가서 전달이 안 돼가지고요.
근데
어느
이거-
부분이 다시 잘못된지 말씀해 주시면.
palmar vein, left inferior palmar 보면은 그 color activation map이 거의 simultaneous 아니야, PV가. 맞지? inferior palmar vein. superior palmar vein은 바깥에 들어가는 게 보이는데, okay? Look at the inferior vein. Looks like activating all around simultaneously.
한 번에
봤어? 그지? 분명히 거기 맵 포인트가 wrong이야. 잘못 찍은 거야. 그 맵버가. 그러니까 수정을 해야지. 그지? 그러니까 그런, 그렇지. 자기가 생각했던 거하고 맵이 틀리면은 가서 EGM을 같이 보면서 correction 해야 돼. 오케이? Re-edit your signal. 아까 우리 그 octave mapping 했을 적에 그 high resolution small fragment signal하고 그 위에 noise를 봤으면은 타이밍을 봤으면은 maybe you could figure that out faster. 그 다음에 once you finish your map, you want to entrain the area that you think that's where the tachycardia mechanism is. And then you find the best conceal entrainment and returns timing of the EGM, and then probably you can ablate it. Usually, probably this type of tachycardia, you can get rid of 1 or 2 burn usually. Yeah, that's RIPB. It's not a posterior reentry, no. This posterior reentry looks like macro reentry tachycardia. So you break through, lower insertion like a Marshall, rotate it both way, come back in. Okay. So it's not a macro reentry. I mean, figure-8 reentry. This is a single epicardial breakthrough reentry. The circuit is in the left pulmonary vein carina and then Liga Marshall. That's what I would say. Okay. So you had the burn in 3 area, 2 area. I can
여기서
see
이제 오블레이션 또
yeah.
타키카디아는 터미네이션이 됐었고 그 이후에
Yeah.
LSPB를 다시 아이솔레이션을
Isolate.
시켰습니다.
Very good. Okay. Very good. Wonderful. Yeah, good case. Good mapping case to learn.
네, 근데 저희가 사실 포인트는 엔트리먼트를 안 했었거든요. 이게 매핑에 좀 더 공을 많이 잘 들여서
그러니까
사실 오퍼레이션 타겟을 굉장히 잘 잡아서 메커니즘 잘 확인했다고 생각했고 엔트리먼트를 해도 그게 달라질 거라 생각하지 않아서 해당 부위에 이제 오퍼레이션 진행했는데 그래서 보팅하려고 했었습니다. 엔트리먼트를 하는 게 좋을지 안 할지에 대해서.
그러니까 특히 마크로 리엔트라이나 마이크로 리엔트한 타키카리를 서스펙트 할 적에는 오블레이션 하시기 전에 꼭 인터뷰는 해야 돼요. 3D 맵은. 왜냐면은 컴퓨터 뭐 하이 레졸루션 맵 이런 게 도움이 되지만은 사실은 ultimate하게 determine 하는 거는 still EGM. So you do electrophysiologic maneuvering finer just before you ablate. So you select a target ablation, you think that's the right area. Before you burn, just do quick entrainment. Doesn't take it too long. Then there will be conforming further perfect match, then you're going to be successful. But then sometimes return cycle is longer than 30, 40 milliseconds. No, probably not the right site. Okay. So don't burn without entrainment. That's the message. I don't care what kind of 3D mapping you use. Navix, Rhythmia, Octave, Pentaray, doesn't matter. This is just cartoon. Can be very wrong.
클리니컬 타키카디아가 터미네이션 되거나 체인지가 생길 우려 때문에 일단 그냥 진행하긴 했었는데
무슨 체인지가 바뀐다고 타키카리아가?
워낙에 직전한 거는
네.
타키카리아가 바뀐다고? Is that your concern? 타키카리아 터미네이션 된다고?
터미네이션 되거나 이제 체인지가 되는 경우들이 있어서
그러면은 체인지가 됐으면 그게 무슨 meaning이야? Let's talk about that. That is important. You just talk to me. If your pace, you think that your site is right, but you entrain, and then you tachycardia 엔트리만 하는 중간에 바뀌느냐, 아니면 페이싱이 끝나자마자 바뀌느냐. Also make a difference, right? Correct?
네, 맞습니다.
그러면은 엔트리만 하는 중간에 바뀌는 거는 probably you're not in the right site. Okay? 그렇지만 엔트리만 하고 나서 바뀌는 거는 still possibly you could be right side, right proper area, except you created maybe unidirectional block and the other way around. Therefore, tachycardia change the pattern. So you need to look at your EGM carefully. And that fragment signal that you are looking at the early, that could tell you the answer. Okay? If that's the still critical dependent tachycardia, only exit site different, that potential is still going to be there because that still need to be activated. So there's a lot of things that you don't need to worry about. So as far as our experience, if you pace 20 milliseconds earlier faster than tachycardia cyclings, I think a chance of terminating tachycardia is very unlikely. Maybe you change a different tachycardia, as you say, it's possible. But usually that does not happen, especially people who had multiple ablations and a lot of scars. Because of that channel is a dominant scar mediated channel, so it's very stable. So please do. It's worth the risk, okay? That's my experience. Okay. Can you hear me? That's it?
예, 예. 감사합니다. 사실, 그리고 메파테트에서는 그 사이트에서 포텐셜이 잘 안 보이는 게 확인됐었고, 알프 하고 나서 타키카디아 터미네이션이 됐었습니다. 그 오브레이션
네.
사이트 이렇게 확인됐었고,
아.
10초 정도 알프 하고 나서 터미네이션이 됐던
음.
게 확인됐습니다. 그리고 나서 이제 LSPB 저 오브레이션 하기 전에 CTI 블락을 디퍼런셜 페이싱을 해서 확인을 했고,
네.
네, 아이솔레이션을 하고 시술을 마쳤었습니다.
Okay. So a lot more fun to do redo cases than just new afibrillations, right? Because you have a lot more electrophysiologic maneuvering to do and then learn a lot more things. That's a chance you test your EP. PDI is not a much of a intellectual business. But it is important for us to do well because patients need help.
PBI 하고 나서
Yes,
에피카디아
sir.
스터링 때문에 엔도카디움에는 시그널 없는데 그 안쪽에 세컨다리 브랜치 쪽에서 포텐셜 찍고 남아있는 경우가 있지 않습니까?
Right.
이 경우에
아.
유니폴라 맵이 유용하다는 그런 리포트가 있나요, 혹시?
That is correct. Yes. No, the current state of art AFib ablation, like potential guided ablation, we need to do baseline map in sinus or CS pacing, and then you do PBI, and then you using same pacing cycle length, the same pacing site. You do remap ablation site area, except you have a baseline unipolar bipolar map, right? Before the ablation, right? And then you use that as a reference, and then you compare. If you don't baseline map, you don't know what was the unipolar baseline before, so then you can make a conclusion. But if you want to do that, you better have a baseline sinus rhythm, CS pacing, high resolution mapping, carina and ostium, and then you deliver energy, and then you want to do remap. That's what we do these days. I mean, it's not a, earlier there's a paper written by the European guys, did a unipolar EGM guided the AFib PBI, but there is no redo mapping the data. There's nobody ever done it. But we do that since we've been using high resolution mapping to minimize the recurrence. Okay, because as you know, sometimes we do only not entire PB ablation. We do only a potential guided ablation until PB isolation happens. So that type of cases, especially, is even more important to do post-ablation mapping. Make sure that there's no high voltage unipolar area left. So if you compare to the, let's say, baseline unipolar area was a 5 millivolt, and then you post-ablation, you still have a 3.5 millivolt. No, that tissue is not dead. So you need to ablate more that area. Okay. So I think a related voltage is important because since we don't know what's the normal unipolar voltage of left atrium in human yet. Make sense?
네, 유니폴라 데이터는 지금 뭐 1000명 이상 모아놓은 게 있어요.
그러니까 한번 들여다봐. 왜냐면 I think that could be interesting paper because in our experience, we've been doing the last 3.5 years, we clearly have reduced the recurrences quite a bit. No question about it. So I think it is another extra work, but it's pretty quick now because a high resolution mapping can be done PBI, palmar vein area only very quickly. But as long as you have a baseline to compare before the ablation and after, it will give you a good idea about how much your efficacy of ablation was. Because you're going to have a related bipolar as well as unipolar voltage reduction, right? So those are the important concepts, I think. But I don't think anybody ever done any study systematically, as far as I know. Okay.
네, 선생님 오늘도 감사합니다.
아유, 감사합니다. 수고했어요, 전부들. Thanks for teaching me a lot.
다음 주에 서울에 오시는 거죠?
예, 서울에서 뵙겠습니다.
네, 다음 주에 뵙겠습니다. 네,
예, 감사합니다.
감사합니다.
Have a good weekend. Bye bye.
네, 감사합니다.